Welcome, everybody. And today I'm really glad to have with us Patsy Fuller because she has a lot of expertise in working with people with a history of sex trauma in the virtual environment. And she attended one of our full certificate programs and had just a wealth of knowledge and experience and great information to share throughout the training. So I invited her to be with us today to kind of give us some insights in terms of working with that population, how to be helpful. So she's a proud native of Central Louisiana. She has her provisionary licensed professional counselor in Louisiana. She has over 12 years of experience in the mental health field. Over the span of her career, Patsy took on a special interest in males with childhood sexual trauma and its effects on their adult functions. Her passion is in group psychotherapy and support groups. In 2019, she started a community support group for males called Men Grow, as a way for men to build a healthy community support and address men's issues in a safe environment. She began working for S.T.A.R, S-T-A-R, since March of 2020 as a counselor. So, Patsy, thank you so much for being with us.
You're welcome.
I look forward to our conversation. So you got started with, working with males with sexual trauma and how it impacts them in their adult life and helping them heal from that in a safe way. So I was wondering if you could just kind of describe the work that you do. What does that look like?
So it's really, honestly, it's really not far from traditional counseling. It's just the population that we provide it to. And honestly, mental health is not really primary because I'm not treating mental health. I'm treating the symptoms associated with the assault. So, depression, anxiety, some PTSD. I don't do any diagnosing.
Mm-hmm.
So we pretty much focus on those three diagnoses. Anything other severe, then we would refer them out.
Oh, okay. Yeah. So you're dealing with the symptoms.
Pretty much.
Yeah.
A symptom reduction plans.
Oh, okay. All right. Yeah.
Like that.
Yeah. And why that particular niche that you chose?
So, because so backing up some, I really got into it when I was working in addictions at a psych hospital. And I realized how a great percentage, at least 70% of the population has had some form of sexual related sexual trauma. As children and as adults. And it contributes to their desire to engage in substance as a way to cope with that trauma rather than working on that trauma.
Okay.
So that's what started the niche. So now being in it, people who don't experience, don't use substance abuse as a coping method, and people who do, they both have had the same kind of trauma. So it touches their life all the way around. So working with survivors, I'm actually helping them restabilize their marriage, communicate better with their children. So working through that trauma, it touches all of them. It touches them holistically, shall I say.
Yeah. So, and then working in the virtual environment, rather than them being in the same room, right? Working through video. Is it video or phone, or is it messaging? How do you typically work with clients working virtually with them?
We do our intakes over the phone, and I make it required that we do video.
Okay. For the intake or what?
For the once after the intake.
Okay.
For the actual services,
yeah,
I require video.
Oh, okay.
And then I have one particular survivor that we do phone sometimes because we've been working together 6 months.
Okay.
So she's capable of just doing the phone.
Uh-huh. Yeah. And why do you require video?
Because it is closest to in person that I can get. And with the immediate transition when COVID took place, like we were doing office, then next day you can't. So that transition, like I still needed to see their face. I still needed to have that interaction close interaction as possible. And then especially first meeting them, I need to learn how to assess them. So just doing their audio wasn't really effective for me.
Mm-hmm.
But once I was able to learn them and assess them, then if they needed to just do a phone for a crisis moment, then I was comfortable with that.
Oh, okay.
But yeah.
Yeah. Yeah. And you have some protocol for security and privacy in terms of your consent forms,
Yes.
et cetera, when working with clients virtually.
Mm-hmm.
Can you share what that is? Because especially with people who might be in, maybe abusive situations or at least history of abuse, there's some things you have in place
So our president of S.T.A.R and the the director over counseling came up with this. Mm-hmm. So to ensure that we meet the requirements of our funders, the way they did it was we used DocuSign. Mm-hmm. So when everybody comes through advocacy. That's the rule. So advocacy does a mini assessment, and then we send out a remote consent form, and that's them consenting to remote services. So it's like a blanket document. It entails anything that's not in office. Mm-hmm. So that's phone, that's text, that's email, anything that's not in person. So first they consent to that, and then they consent to the policies and procedures for S.T.A.R as a whole.
Okay.
So, but it gets tricky because we work with the Department of Health and Human Services, DCFS. Uh-huh. So child protection agency. Uh-huh. So it's twofold then. So first, the caseworker has to give consent. And then the caseworker gives consent to the foster parents. And once that takes place, then the foster parent has to agree to certain policies and procedures as well.
Oh, okay.
Right. It's like so many layers, and especially with the minors. And if the minor is at least 15, they have to consent as well to allow the remote services also. Mm-hmm. So even if the caseworker and the false parent want it and the 15-year-old don't, then we go with that.
Right. Sure.
Because part of S.T.A.R is giving people the safe space to take their choice back, because rape and assault takes their choice.
Right.
So they have a choice.
Yeah. Yeah. And then there's some other, I think you have some other things in your consent about privacy and security during the sessions, right? To
yes.
That it's a safe location, and if there's interruptions and that kind of
thing. So that one is suicide. So doing my initial assessment, that's when I assess whether I'm gonna take on this. Because remember, we are specialized in sexual assault. We're not a community mental health, so we have the right to assess for culpability.
Okay.
So doing that initial assessment, if they have a history of multiple attempts of suicide or just anything in there that makes raise an eyebrow, I have two choices. I can take the case and put in a plan. And the plan is they have to have a support person that both consent to the remote services and S.T.A.R's policies and procedures. And they do a third consent to say, I can call you and say, hey, this person went offline. I fear this or whatever, and they have to act. If they don't act, then we go to the next step.
Okay.
And so they, but they're only consenting to emergency procedures. They're not consenting to get day-to-day updates on their person's treatment. Right.
Sure. Yeah.
Yeah.
Yeah. So they know what they're getting into. They know that they know that they are choosing to be that patient support person.
Right. And we're nonprofit. So they're not paying for services. So all these services are free. So if I do take somebody that has high risk, I have to have that support person a part of that initial assessment.
Right.
To agree to this.
Yeah. And what about in terms of the safe environment on the client's end when having virtual sessions?
Well, with COVID hit, they didn't have policies and procedures for remote services. So the way S.T.A.R did it was we had to identify. That's why I do video. That's why I had required video, because in our progress notes, we had to identify the person's location. So for example, you and I, the top part of my note specifies location, and I have to specify exactly where they were. For example, you are in your in an enclosed space in your private bedroom. I would ask you where you were, what part of the house, and I would document that in my notes.
Okay.
So that was our attempt to be as safe as possible. And if they were in an environment with their abuser, they had an option to attend, do services at the same, like at the hospital. So, because we have SANE nurses, which are sexual assault registered nurse, they had an option to go to the hospital and speak with the SANE nurse and let them know that, hey, I need to be able to do my session here. And she had a little space that she would let them sit at, but we didn't have to use that option.
Okay. Yeah. And you're doing groups, or you were doing groups virtually through video?
They still do it.
You still, yeah. Mm-hmm. Yeah. And what's been your experience with that? Doing groups say through video versus on site, and what different kind of protocol or consents did you have to have, making that transition?
Well, they're not therapeutic groups, so let me say that first.
Okay.
So we only decided to do support groups because of COVID, and then the isolation people were experiencing. So we decided to do support.
Oh, because they were needing support. Yeah.
Right. So we did support. So with support is a lot more laxed. And we only offered it to people that were already current survivors in the program. So they had already completed all those policies and procedure. But we did do a group assessment to see who would be appropriate for what groups, and mesh what people would do well together. Mm-hmm. But I like the group support groups virtually. That was my favorite.
Uh-huh.
That it worked out the best.
Oh, okay. More so than on site?
More so than on site, and more so than the individual virtual sessions.
Oh, okay. Yeah. Tell me about that. How come? Like, what do you think was helpful about that?
The individuals who chose to participate in it. I don't think it was anything I done different. I think they wanted the support. So they would show up and they would engage.
Yeah.
And they liked the fact that they didn't have to leave their home to get the group support. Mm. So they would be in their pajamas at 10 o'clock.
Wow. So you had more participation, people showing up more, engaging more. Mm-hmm. Yeah. They probably felt safer.
In their own space. You had some on the laptop, some on their own phone.
Uh-huh.
So it was a whole lot better.
Yeah. Was there like a group agreement form or anything about confidentiality, or?
No, we didn't do a signature group agreement. We just did a verbal one. Uh-huh. And the people that we had in this group had been in the program longer than 6 months.
Okay. Yeah.
So they were comfortable with the S.T.A.R staff. They just went through the process of getting to know one another.
Yeah. All right. Yeah, that's great. Yeah. During our live webinar events that we do with clinicians, we do a self-care piece often. at the end. And it's amazing how many people stay on longer after the training's over just for the self-care piece, just to support each other. It's really incredible. It's powerful.
Yes. And so also Pacific, so this particular group, this group was a secondary survivor because S.T.A.R provides services to primary and secondary.
Oh, okay.
So when you talk about policies and procedures, secondary survivors have their own subset. They get the same remote and the same consents, but what we didn't do a signature agreement, but we did a verbal when we got ready to do the group assessment. So we talked about not sharing other people's information as far as their kids, because these were people who children were assaulted. So we were really specific about this group.
Yeah. Right. Yeah. Very private information.
Yeah. And it was helpful because to know that another parent has experienced what you're experiencing, they didn't feel alone. So I think that's the other reason that the participation and using telehealth was an advantage.
Right. Yeah. And you work with kids also, right?
Yeah. Not my
cup of tea.
Right.
Yeah.
Not my area expertise.
Yeah. Yeah. Are there any differences there in terms of, say, consents or procedures working with the kids, like having someone on site with them, or?
It's the same. We use the same plan for the suicide plan. So, for example, I have a 9-year-old. I had a 9-year-old. For us and for me as the individual clinician, there had to be a parent in the home. There was no way I was going to conduct the session with someone not in the home. Plus, the kid is 9 years old.
Yeah.
And I needed somebody over the age of 18 that could make a decision if a decision had to be made. And that person was already a part of the agreement. So I would tell parents, if you sign them up, you have to be somewhere in the home. It can't be a brother or a sibling or a neighbor. Because if whatever, I don't know what happens, I just need them to be there to say, hey, this is taking place. We need to make these decisions. Yeah. We're talking about sexual assault.
Right.
And the process and whatever happens that day, that person could probably really tap into buried memories. And I need somebody to be there to be able to support.
Yeah. Right. Yeah.
And it doesn't have to just be suicide, but just that emotional support.
Yeah, that makes sense. Yeah.
So yes.
Wow. Definitely. Well, you're doing great, super important work, changing lives. So really appreciate what you do, and sharing with us how that works and your experience with that. So thank you very much, Patsy.
You're welcome.
Yeah.